Welcome everyone to the Beauty and the Surgeon podcast. I'm Amy, I'm a nutritional therapy counselor, and I'm joined today, as always, with Dr. Jason Martin. He's a board-certified plastic and reconstructive surgeon. Dr. Martin, how are you doing?
I'm doing really well. Amy, how are you doing today?
I'm good. I'm excited because today we're actually talking about a surgery for men, only for men.
Yeah, it's one of my favorite topics. First and foremost, I'm a man. We've established that previously.
Yes, I'm a woman.
Secondly, we're talking about gynecomastia. Now, we have talked about this before. We have an episode on gynecomastia, but that was extremely OG.
Yeah, it was almost 3 years ago, about 2.5 years ago, almost 3 years. And it's great to do this again because back 3 years ago, we were only audio broadcasting our podcast. So if you are interested in seeing the slides and videos from today's podcast, please check us out on YouTube. We're at Jason Martin MD on YouTube and also at Beauty and the Surgeon podcast on Instagram. So there's some great slides and also a cool video that goes along with this podcast. So it'll be fun to talk about gynecomastia again, but also have some fun visuals to go with this version.
And things have changed in our practice for gynecomastia in the past 3 to 4 years, for sure. So updating this topic is really helpful. Now, this is a very common topic that people reach out to us about in our private practice. So people watching this or listening to this may not think that this is a common problem that people deal with. It's actually very common, obviously, for men, and it's a common problem that men seek out treatment for.
Mm-hmm. Yeah.
So I think this is going to be extremely informative. Also, we have before and after pictures of surgery. So we're going to break it down, gynecomastia 2.0. 2.0.
So let's first talk about some of the causes of gynecomastia.
So our previous podcast, we kind of went into this a little bit, but it's fairly simple. I think it's, if you look at it like this, in most cases, it's usually in a relationship between the hormones in your body, mm-hmm. right? So estrogen, which is the female hormone, testosterone, which is the male hormone, and that balance will decide how you maybe appear in your body, but also how your breasts present. Now, Amy, do men have breasts?
Yes, they do.
Okay. We established that previously.
Well, actually, there was a great outtake that Nils did not put in our previous podcast where I ask you after the podcast is over why men have nipples. But either way, yes, it is well established that.
Yeah, you asked that question. It was, that was inane. I don't even know why you asked me that question.
Because it was really funny.
It was kind of funny, actually. Yeah, so men have breasts. I mean, they have a chest, and men like sculpted chest, and obviously they prefer not, in most cases, not to have breast tissue. But men have breast tissue just like women, just not as much.
Correct. Yeah. And one of the things we talked about in our previous gynecomastia podcast was the incidence of breast cancer in men and women, whereas women have a 1 in 7 chance of developing breast cancer in their lifetime, which is horrifying. For men, it's actually 1 in 1,000, which doesn't mean it's non-existent. So
right.
Men have breast tissue. You can have issues with that breast tissue just like a woman can.
And actually, and this is not often discussed for men, but they also have the genetic disorders mm-hmm. that are related to breast cancer. Yeah. So BRCA1 and 2, and that definitely increases their risk of having breast cancer. Mm-hmm. And it's less than 1% of all breast cancers, I think, are in men, but it does happen.
It happens, yeah. So.
All right, so we're talking about gynecomastia, which is basically male breast, the development of male breast. Now, the causes of gynecomastia are numerous. If you look on our YouTube channel at Jason Martin MD, we wrote down many of the reasons that you can have gynecomastia. The first slide shows a lot of the medications. And medications are a big cause of gynecomastia, just FYI. So if you do have gynecomastia, you need to really look at the medications you're taking and try to find out if maybe one of these medications is contributing to this problem. So Amy, let's kind of go through those.
Yes, I think one that most people are going to automatically assume might cause some issues with gynecomastia are androgens, anti-androgens, anything that's affecting your hormones,
right?
Positive or negative is.
So an androgen, if you think of androgens as more like testosterone, male hormones, there's a lot of medications that actually inhibit testosterone. Mm-hmm. So one of them, a big example is hair loss. So Propecia, for those of you who have thinning hair and you've been on medications, those medications actually inhibit androgens or testosterone-like compounds, which then would artificially increase the effects of estrogen that's already in your body. By the way, men have estrogen floating around their body, just not as high of a level as testosterone. Another one is prostate. I forget the name of the Proscar, I think is the medication. Prostate cancer or prostate medications do affect androgens, which then help prostates. They decrease the size of the prostate, so it helps with urination. These can actually lead to decreased testosterone levels, proportionally increased estrogen levels.
And spirulactone is one that also is pretty widely used for acne.
Right.
So that's something that you know, depending on where you are in your life cycle, right? You may have been prescribed that as a young person, but sometimes, you know, when you throw off, and we'll talk more about some of the tests we look at to look at hormonal issues related to gynecomastia and other just hormone imbalances, some of these can have a lasting effect. So if you suppress a hormone for a certain amount of time, your body can kind of downregulate its natural production. So it may not kick back up like it should, even though if you stop taking one of these medications.
Okay.
Which can be very true of anabolic steroids. You know,
big problem.
Yeah, we have a large population base that are professional athletes and also performance athletes like bodybuilders, and you know they may cycle through some type of steroid use during their career.
Yeah, they gear up, whatever the layperson term is. It's terrible. I mean, especially along this line, gynecomastia is very prevalent in the bodybuilding and you know those kind of competitions.
Yeah,
because of the stuff they're putting in their body.
Yep. And that tends to persist even after they may stop taking those anabolic substances or stop taking steroids. So that's definitely something to be on the lookout for. The HIV regime and therapy, like the antiviral therapies, I know that they are associated with gynecomastia, but is it just because of what they do to the hormone production?
Yeah, I think so. I'm not totally sure, actually. And I thought that was really interesting.
They're antivirals.
That's not one that I had remembered, you know, that we emphasize. But, you know, HIV medications are very common now. And, you know, with HIV, you usually live a fairly normal life and you just suppress the problem with these medications. So those people apparently struggle more with gynecomastia. Anti-anxiety medication, like Valium. Antidepressants. I mean, this is huge. Like TCAs. How prevalent are antidepressants out there?
Very prevalent.
Exactly. And you know, a lot of times people that have gynecomastia have image issues, and they struggle. They may struggle with their body appearance, and that can lead to depression. So these things kind of fulfill each other. Antibiotics, cancer treatments, heart medications. This was really interesting. Calcium channel blockers, and even stomach emptying medications like Reglan, which we give in the hospital sometimes for people that have stasis or their stomachs aren't working that well because of the pain medication. So there's tons of medications out there. If you struggle with gynecomastia, go see your doctor. Talk to him or her about the medications you're taking, and say
have taken,
and ask them specifically, do you think this is contributing to my gynecomastia? So.
Yeah. So in addition, there are several.
These slides are very chock full of information.
They're detailed, but that's the good thing though about being a visual and an audio podcast is the people who are listening. The people who want to go read a lot.
I'm just telling you, when I see a slide like this, I'm like, I can't read it. I'll go with the first one and then I'm done.
Right. Well, so in this slide, we're talking about some of the other health conditions that might contribute to gynecomastia. And there are quite a few. And most of them are going to be things that are related to hormonal regulation in the body. And or things that break down hormone in the body. So aromatase is an enzyme that helps convert androgens into estrogen. So
and it does it peripherally, and it does it in all different areas like the brain and other parts. But the main thing we're focusing on here is fat, your peripheral fat. So people that are overweight or obese will have a higher conversion of androgens to estrogen, right? Which is why with breast cancer, a risk factor for breast cancer is obesity, right? Because it increases your estrogen level. Most breast cancers respond to estrogen. So remember that aromatase, which is primarily in fat, in this scenario which we're looking at, is going to be more common if you're obese or, or if you're even slightly overweight. So that's an issue, obesity.
Yeah. Health conditions that are going to be mostly hormonal related are going to be things like hypoglandrism, or these symptoms like of metabolic disorders almost that are affecting the way that your pituitary gland functions.
Right.
So we talked in our first podcast about gynecomastia a lot about why the pituitary function has a lot to do with your thyroid and then your hormonal production as you age, especially because
what's the axis you guys all talk about?
HPA axis.
HPA axis.
Yeah. But as you age,
it doesn't matter. You don't really need to know the information. Someone throws it out at a dinner party to say HPA axis.
Dysregulation. Yeah, it's your HPA axis dysregulation. But as you age, your testes and your ovaries stop producing your sex hormones, so that your pituitary gland takes over a bit. So there's a definite, if you're having issues already, if you have a baseline issue with your pituitary function, that's only going to get worse as you age. Also aging just in general, because of the issues that occur, it can be in puberty.
tumors. That's a big thing. These are rare, but you have these soft tissue tumors or ovarian tumors or tumors in the testes or the pituitary that can secrete hormones and can really mess with your system. Okay, and then we talked about thyroid. Increased thyroid function or increased thyroid hormone can lead to gynecomastia. So that's called hyperthyroidism. The things that I remember from training are like liver failure and kidney failure. Because you'd see those patients, they almost universally had some gynecomastia or male breast. And that's just related to the disease process and the hormonal imbalance.
Right, you don't get rid of your estrogen. So you're not breaking down those hormone byproducts as effectively. So they build up in your system, lead to gynecomastia.
Malnutrition and starvation, which is really interesting.
Yeah, the starvation response, it's an interesting thing.
We talked about that, didn't we?
Overfeeding. We talked about overfeeding following starvation. And you're just in a very highly storage.
I think it's kind of funny now that we're way more information associated. Before we were talking about things we were kind of interested in. Now we're trying to help the public out. Because I do remember this part from the previous podcast.
And the reason for that is when you're in a period of overfeeding after starvation or malnutrition, your body is very primed for storage. You're basically... it's trying to recover what it has been deficient in for a long time. And again, if you're storing excess fat, you're having extra aromatase, you're getting excess estrogen buildup. So it kind of just snowballs into gynecomastia, potentially.
In a man's life, the incidence of male breast formation per memory is like greater than 60%, maybe 70, 80%. So most men in their life will have some gynecomastia.
And it could be transient.
Yeah, a lot of kids have it, like, teenage years are going through this transition. They get male breasts and it kind of resolves. Some of that persists. And then the other parts are, kind of like pseudo gynecomastia, meaning that it's related to obesity. And that's technically not an increase in the breast buds. But usually you see both. Usually you see that the breast buds or breast tissue is increased in size, and there's fat there too. So it's usually kind of in combination.
Yeah.
All right, so Aim, we see a patient, and they come in our office, and they think they have male breasts, and obviously they do. It's pretty easy to kind of figure that out. So what do we do? Like, how do we work them up? What things do we ask about? How do we go through that process?
So we ask a lot of the basic health history questions that might be clues into what could be happening, but we really want to make sure that someone doesn't have some type of underlying issue. For the most part, most men who come in have gynecomastia. It's came up for whatever reason. It's going to be easy to treat. We treat it once and it's gone. However, if you have an underlying issue, treating your gynecomastia surgically may not actually get rid of it. It might come back. And that's what we want to try and prevent by doing a little more thorough investigative exam with patients beforehand. And there are definitely things that we might send them out for, which is some routine and some other, interesting lab work just to make sure that they're normal.
And if you look at our YouTube channel, we have all those labs: liver function tests, FSH, LH, which are related to hormone production, thyroid stimulating hormone, estrogen, estradiol, testosterone. It gets a little bit complicated. Actually, if you've ever been to a hormone doctor, they check a lot of different things. Some check free testosterone, some check the testosterone total levels. And so it gets a little bit more complicated. And we didn't really want to go through that in this discussion because it can weigh it down. But just know that a lot of people need their hormones checked. And since our last podcast, we do a lot of gynecomastia surgery in our office. We've had a few patients that actually have had recurrence of their gynecomastia who've had to go to a specialist and then get worked up, and they found that they had severe problems related to their hormones, not their overall health.
Right, and it's for most men, it's a balance issue. So it's not that they're completely deficient in estrogen or testosterone. It's that maybe their estrogen is too high, even though their testosterone is normal. It could be that their testosterone is low, and that their estrogen may not be high, but it's high in comparison to their low testosterone. So it's not always just needing more testosterone for a lot of our patients, which is surprising. It's sometimes suppressing or helping them metabolize estrogen more efficiently that makes the difference.
And it's anecdotal, but for our patients, they were all treated with anti-estrogen drugs, not
Tamoxifen.
Increasing testosterone. And some of them even had lower testosterone levels. So they, instead of like reflexively, you would think, I'm just going to increase someone's testosterone. What they did was actually do the opposite, is decrease the estrogen, which that ratio changes, and then the body reacts differently. And I think a lot of cases reflexively makes more testosterone. So it's been very interesting. And I do think it's really important that if you struggle with male breast, that you need to understand that surgery is the treatment, but long term, you may also need to have medical, a medical evaluation by a hormone physician, an internist, someone who has an understanding of hormones and how they affect, your chest and your breast. So
I'd say that's especially true for two certain type populations of men, those that are over 45 and maybe just dealing with normal age-related issues with hormone function. And then also anyone who's ever taken anabolic steroids for sports enhancement or any other reason. Like those two populations are probably more likely to have downregulation issues and or excess estrogen related to age and then lifestyle.
I totally agree with that. For the young kids, like the 16-year-old, what you usually do is wait a couple years, 2 to 3 years, and see if it resolves. In most cases, it does.
Yeah, it does.
And then after that, you can do the gynecomastia surgery. And I don't think that you need in those cases, you do a full exam, you check their testes, you do all this kind of stuff that you probably need a hormone workup in that situation. And we just had a case like that.
Yeah,
the kid was young, low 20s, and he's like, "Look, it's not going away. We all know. Can I just take care of this?" And
Healthy body weight.
Yeah, super happy. But those people in their 40s, 30s and 40s, where it's getting worse and worse. I mean, clearly this is indicative of a problem in their body and their hormone balance. And I think it's really important in that situation that you consider getting an evaluation. We personally work with hormone doctors, and we can refer them out. It's reasonably priced. Sometimes insurance won't cover certain things. But I think it's an important point.
Yeah, especially if you don't want it to come back,
which is
definitely if you're here seeing us.
Yeah, we like people. We like you to come back, but we like you to come back after surgery
for something else
with a full result. Yeah, exactly.
Yes. So we have a great slide here that shows the different kind of grades, essentially, of gynecomastia or progressions. So just like anything else that we kind of give a scale to, I would say most of our patients on this are going to be more in between a 1 and 2.
Right.
It's rare that we have a patient that gets to 3 or 4. That's really more of a ptosis of the actual descent of the breast tissue.
So ptosis means droopiness. I have to define Amy's medical words.
Yeah. So it's more so than just like an enlarged breast. In the cases of a grade 3 and a grade 4 is actually like actual skin laxity and like droopiness of that breast tissue.
And I think grade 3 and 4 you see a lot of times with weight loss. It's so common now with weight loss surgery. We have tons of patients in our clinic that have had weight loss either on their own or with surgery, and you'll see these grade 3 and 4s.
And even so, in most of those cases, and we actually had a patient several months ago who came in who was probably close to a 3, but he was like 23, and like just give it a year. He had just lost weight like within the last 3 months. Like if you give your body some time,
I remember him.
You'll probably get to a 1, and then we should address it then.
And he also had kind of good skin integrity.
Great skin integrity.
So he's probably going to bounce back a little bit.
Yeah, just like after breastfeeding for women, if you give your body some time, your breast will bounce back.
Yeah.
So for men too, if you lose a lot of weight.
It happened with me after my breastfeeding. I bounced back.
They bounce back. Oh, so that's great. You're really progressive.
Me and my salt.
Yeah. Nice. Yes. So what are some treatment options? There are 2, essentially. We have a surgical and then a minimally invasive and or non-surgical.
So you've already done your workup. Everything's kind of been figured out from a hormone standpoint, but you have this gynecomastia. And gynecomastia is easily treated. And this is the one thing, this is the take-home message. So the men listening to this, they're like searching, they're frustrated. A lot of men don't understand that we do the surgery in the office under local anesthesia, and it solves the problem. So you have 2 different options for gynecomastia. You can surgically treat it, and there's different types of surgeries and non-surgical. What would be a non-surgical treatment of gynecomastia?
I guess, if someone had just dealing with it with hormones and or maybe some external only treatments, if someone had more fat related gynecomastia
some
versus
weight loss
breast tissue.
With some skin tightening.
Yep, some external skin tightening, do hormonal therapy, to address it that way. And for some men, that might be enough. Especially if you're a grade 1, like getting your hormones balanced, doing some external skin tightening if you need it.
Focusing on the chest, torso for exercise,
do
strength training. Yeah.
And that a lot of men who have gynecomastia are really hesitant to work out their chest because they don't want to make it look worse.
Yeah.
So, they're already wearing like compression tops all the time. Like the last thing they want to do is build up their pecs. So, but that might actually help if you're...
We literally just had a patient tell us that yesterday.
They didn't need to work chest.
Yeah, because he doesn't work out chest.
You don't want to make it worse. Yeah. And so, that's definitely something, once you kind of make sure that you've got your hormones balanced, you're at a healthy, manageable weight, like actually doing a little bit of muscle building will help bring that tissue back in.
Right, and you've maximized your medications. One thing we didn't mention was marijuana, which has a higher incidence of gynecomastia formation. So you optimize your life. And then, with any surgery, before considering surgery, you should do all these things anyways. Smoking, you got to stop smoking. In most cases, though, and like in almost all cases, you're going to have to consider some surgery if it's persistent and it's not going away.
Yeah. So the surgical options, we have a picture that shows several ways of dealing with gynecomastia. For us, we're going to almost entirely be on the very far right-hand side of this, which is just liposuction with perhaps a breast bud excision.
And that, real quick on that, the breast bud excision is the breast tissue, and you excise it but from making an incision around your areola. And that heals really well. Some people get a little bit concerned about that. No, that areolar excision in men specifically heals very well, and you just don't see it.
You really don't. Yeah, men heal very quickly. And it's not like it's a super traumatic surgery, which helps also. I mean, it really is fast. The actual part of us taking out the breast bud itself is the fastest part of the surgery. It takes us longer to numb up the area than it does to take the breast bud out, just because it's very well visualized.
That could be the surgeon taking it out.
That could be. He's really good. But no, it's a visual.
I mean, come on, this is called spade here.
It's right there. It's not like you have to.
No, it's not very hard. Yeah. And, if you have a lot more problems, usually with weight loss or severe gynecomastia or moderate to severe, you can make an incision along your inframammary fold where basically your breast meets the chest wall and make an incision all the way around the areola. Or you could even make an incision all the way across your chest, which is the least desirable, in some cases has to happen. You could even do a lifting kind of scar, which would be around the areola and straight down the midline below the areola, and even an anchor scar in like rare cases, which would be around the areola, straight down the midline of the breast and along the inframammary fold. There's so many different options here for this problem. In our experience, and again, we're in Colorado, so it's anecdotal, but we tend to do most of our surgeries with an incision around the areola, and we've rarely had to do the larger ones.
Yeah, and those, you definitely have seen, men and women can have the nipple and areola basically pointing straight to the ground. And you see it sometimes in really fit men who have like very muscular chests, and then their nipple and areola is pointing straight down. We should just post a picture of me. My areola is pointing straight down.
I have such pectoralis hypertrophy.
No, you see it even in men who have very well developed chest muscles.
Yeah, you see it all the time.
And if that's the case, if your nipple and areola is pointing straight to the ground and you want it not to point straight to the ground,
good luck.
It's going to be a little bit more involved surgery.
Yeah.
It just is. But it's definitely doable. And I guess it's so funny because like for women, it's like well accepted that like a breast lift is going to probably be necessary in your lifetime. For men, it's really not, but it's the same, same idea. You can definitely lift it back up if that's what it needs.
Sometimes,
but we rarely have to do
sometimes
that.
You need a lift.
Sometimes you do.
Yeah.
So the surgical option for us, though, typically involves some type of assisted liposuction, meaning we use an energy-assisted liposuction to assist in tightening of the skin. Body Tight is an amazing option for this area. Men respond extremely well. Your skin is naturally a little bit tougher and stronger, especially in the chest. So you can put a lot of energy in there with radiofrequency, help that skin kind of contract back down after surgery. A little bit of liposuction, cut out the breast bud. Oh, let me ask you a question, Dr. Martin. You're the surgeon.
I am a surgeon.
So why can't you just do liposuction?
Because in most cases for the gynecomastia, a big part of the gynecomastia is actually the breast tissue. And the liposuction, there is a certain style of liposuction that's very invasive that can cut through that breast tissue, but most of the time it can't. So when you do liposuction, you take out the fat, but then the breast tissue's left. And you can see it on the table. When you do liposuction, oh, by the way, we established before that gynecomastia, male breast, is caused by fat and the breast tissue. So on the table, you do liposuction first and then take out the breast tissue. You can actually see that like their entirety of the chest, whichever side, say it's the right side, is better besides this mound that's right underneath their areola and nipple. And that's the breast bud.
Yep.
And that's what makes it so easy, because once you've done your liposuction aggressively, then it's pretty easy to see exactly where that breast bud is, because that's what's left over. Yeah,
and we've talked before in a lot of our podcasts about for female breast surgeries, like breast lift, we talk about what makes up the breast tissue. So it's a combination of ducts, but also these kind of glands and fibrous bonds.
And a ligament that you can never remember.
Oh my gosh, and I can't remember it right now either. Some dude's name.
I love it. It's the only thing I get you on.
I can never remember. It's my medical blind spot.
Is it Canner? Is it
Cooper's ligaments.
Oh, there
Dr.
you go.
Cooper, I'm sorry. So
like the Cooper ski slope, isn't there a Cooper and
there is Ski Cooper.
Yeah, Ski Cooper.
Ski Cooper. Maybe that'll help me remember. Probably not. Like I don't know. Never gonna get in
What's
there.
What's that ligament? Ski slopes, Cooper.
Skiing Copper. That's Cooper. But that the breast tissue, that is not just fat, has a lot of like kind of substance to it essentially. So like you said, it's really easy. Like even when you lipo all around it, this kind of bulb of the breast tissue comes out pretty easily. And it is a different texture than just fat. So there is fat obviously in it, but like the makeup of it is different.
Fat, especially when you treat it with Body Tight, comes out kind of creamy and almost like a milkshake
Thin.
consistency.
Yep, it's broken up.
Where the breast tissue comes out and it has actual substance and structure to it. I mean, if you lay it on the table after it's been removed, it has the three-dimensional shape.
Yep, it holds its shape.
So, and one of the things that's changed, so we did this 3 or 4 years ago, which is really representing how long we've been doing this podcast before, and we didn't have Body Tight at that time. Body Tight is a radio frequency assisted device that works underneath the skin and melts the fat and tightens the skin. And now we do that universally for all these patients, and it's made our results even better. It's awesome because it tightens the skin at the same time, which is why we don't have to do some of these more extensive surgeries, these lifting procedures. In most cases, you can get away with combining it with some energy-assisted liposuction. Historically, that's been Vaser, V-A-S-E-R, which is great. We love Vaser. That's ultrasound. But Body Tight, which is radio frequency, is like the big daddy. It's coming in with a lot of energy. It makes a big difference. So that's really another thing that's changed.
It has, yep. Yeah. So there's great options. And most men, like you said, are going to need a surgical option. It doesn't mean you're in the OR. Very rare that we'd need to do gynecomastia surgery in the OR unless you need a lift. And in that case we would. But for everybody else, we can do it in the office. You're awake. You're out of the office in a couple hours. So
you and I just say the words together. It just comes out every day.
So we've kind of covered who a candidate is, but let's talk about specifically like who is a candidate for gynecomastia surgery.
All right, someone who's healthy, someone who is a man.
And let's define healthy, because healthy means a lot of things. But for us, healthy means you need to be at a maintainable, stable body weight.
You can't have a lot of medical conditions. If you have diabetes, most likely you will not be a candidate unless your hemoglobin A1C is very well controlled. If you smoke cigarettes, you won't be a candidate. If you have a lot of other medical issues that preclude you from doing surgery, you will not be a candidate for this. So you have to be at a manageable weight and living a healthy lifestyle. You've had to at least have tried to do certain things to be, to rectify this issue that you're having, like exercise and diet. And then also, in a lot of cases, you have to at least have a primary care physician who has helped you work up, what's going on with you.
Make sure have no hormonal issues. Yeah. So, but really, anybody else is? There's no age cap.
There is a little bit. So at least in my practice, I don't want to do kids too young because a lot of times they grow out of it. So that's a mistake that somebody could make is they'll go to an office and the office doesn't care. They're just going to do whatever they want. And then they'll do some 16-year-old kid that probably maybe this would have resolved. Yep. You have to balance that with their self-perception. You don't want to traumatize a kid, in their teenage years because they feel insecure. So it's always a balance there.
Yeah. So we've got a great before picture. Dr. Warren, you want to talk a little bit more about what this picture is showing?
Yeah. So if you look on our YouTube channel, this is actually one of our patients, and it really shows you, obviously what gynecomastia does. He's slightly overweight, but he's not bad. He's in pretty good shape.
He has a normal BMI though.
Yeah, normal BMI. He's pretty good. But he just really collects his fat in his chest area. He actually looks like he has breast. On this picture, you'll see the markings that I put on there. This is where I'm circling things to show the fat that I'm going to take out. Also in this picture, you can see that his areola are different. On his left chest, his breast is more ptotic or droopy than the right side. And you can also see that I drew on the areola, and that's exactly where that incision is going to be. So he has both a breast bud, which is, I told you, very common, and also the fat. So we're going to treat both of those.
Yeah, and his breast buds were actually quite large. And I think it's good to show this picture because we didn't need to do a lot of liposuction on this particular patient. And on some of our patients, we do a lot more liposuction than we did on him. He had a really prominent breast bud.
Right,
and
really that's important. So his BMI or his weight is pretty good, and he still has pretty notable male breasts, then most likely this is a breast bud, not a fat problem.
Yeah. So we have a little video also that's going to just kind of do a...
Let's take a look at this video.
Yep.
Now this video really shows him turning, and you can see all angles of the gynecomastia. This is very, very helpful for anyone listening, specifically watching what gynecomastia looks like. And that shows you every angle. And you can really see it on the profile.
Yeah, profile you really can. And you can also, he was super self-conscious about it in the sense that...
I get it. Like, as a man, I get it. You want to have a sculpted chest, and most men do. And And, it just really limits what he could wear for clothing, especially in the summertime. He's always wearing things that are compressing his chest.
Or loose.
Or loose
both.
or the opposite.
Yeah.
And actually, probably loose is probably more common.
Yeah. And I think that's something else that's universally true of our patients who seek out gynecomastia surgery is that they almost all of them come in and are pretty much always wearing a compressive shirt underneath their clothes.
Yeah.
Like always.
Yeah, there's brand like Spanx is for women, but I'm sure they
just
have
Under Armour. Like they're wearing those
Under Armour,
Under Armour compression tops, or the Nike ones are the two that
the
most
stuff
people
you would
wear.
wear like at a gym or something like that.
Yeah, but like a size too small, so it's like super tight.
Yeah.
So it's just like our female patients that come in and are wearing a Spanx all the time.
Right.
Like this is an issue that like you can compress it, but even wearing something compressive is, especially you can see on this video, if there's a breast bud there, it's not super soft. So you can compress fat way more than you can compress breast tissue.
Yeah.
Unfortunately.
And I think this is like the take-home message of the surgery, because a lot of men don't know that they even have this option. We're playing the video again so you could just see it. And it's just, it's really obvious at all different angles. But I think that's the take-home message of the surgery, just like breast reduction. Like a lot of men don't know that there's treatment for this.
Right. And that the treatment's pretty easy.
The treatment's pretty easy, and you can just like transform your chest. And it takes us less than 2 hours. How long did that case take us?
About an hour and a half.
Yeah. Less
Start
than 2
to
hours.
finish. I mean, and that's
we
like
listened
really
to nice
start
music.
To
He was talking to us the whole time, and then we were done. And then your problem's done.
Yep,
And there's a recovery. Don't get me wrong. And definitely you're swollen. You look a little bit weird after surgery, but within a couple months, you're back at it. So if you actually, again, sorry to keep going back to the YouTube channel, but it's kind of a visual discussion. We have the immediate after on that same patient that you saw the video on.
Yes, this is literally like, minutes after his surgery had finished.
And so he's swollen from surgery. So please do not write in and say, well, I don't like the after, okay? You can shove it, right? He's swollen from surgery, but you can see the amazing transformation right on the table. And he's going to be 50% better from here as time goes on.
Yeah, and a lot of that's because of the body tight.
Right.
The energy will really help contract it in, but then also just the body's natural healing ability to kind of contract in when the breast tissue's not there.
And the reason why you're swollen from surgery is for the surgery itself, to do it with you awake, we put this numbing medication in called Tumescent, and that has saline, lidocaine, epinephrine, and 12.5 cc's of bicarb. Is that correct?
No, it is 10 cc's.
12. Darn it.
It's 12.8% sodium bicarb. That's where you got that from, but it's 10 cc's.
Obviously, Amy helps me make this up. So anyways, that gets into your soft tissue. So even though you do liposuction and suck a lot of this fluid out, that fluid stays in your skin and the muscle and everything around. So after surgery, you're going to be swollen, definitely for the first 24 hours. And then the swelling persists because of inflammation, just normal healing from surgery.
Yeah. So I always tell people though, like we show people, especially men, right after surgery, like this is how you look, because the next day when they wake up and the swelling has set in and they think it's come back.
Oh yeah.
I get panicked calls like that. It's all back. You're freaking out. So it's not back. Like this is showing you, even right after surgery, you're a little swollen, but the next day you're going to be more significantly swollen. We've also created space there for inflammation to set. So you will be swollen, but it's not terrible.
And there is a lot of open space there, and a lot of people will put drains in. We do not, because we found that the body type really helps with that. And rarely do we have seromas or inflammatory fluid collections. But I would say, it's in our hands less than 10%, but it is possible to have fluid collections there that don't just get reabsorbed by the body.
Yeah. And compression helps. We have patients where, again, most of them already have their own Under Armour tank top to put on right after surgery. But you will wear like a smooth compression top right after. We don't wrap with an ACE wrap because it can cause some irregularities in the tissue just because of where that ACE wrap sits. So just nice smooth compression. You can ice after the first 24 hours. With us, we don't want you to ice immediately after body tight because we want that heat to stay in.
Yeah, can you explain that just so people understand? So
why not to ice right away? Yeah, so body tight causes, it uses heat. So radio frequency is hot. It's heating up that tissue from underneath. Now, obviously that heat dissipates right away. Your body's pretty good at creating hemostasis. That's why you don't burn to death.
Hemostasis.
Hemostasis. What did I say? Hemostasis?
Yeah,
hemostasis.
I didn't realize that you grew up in England.
I'm speaking bubonics.
I just don't understand.
I'm adding syllables to things.
Yeah.
But there is still some residual heat that is in that tissue, and we'd like that to stay. That heat is what's kind of helping everything contract.
Tighten up, yeah.
Stimulating collagen, stimulating everything to kind of contract. So
a lot of doctors will have you put ice on right away. We don't. We wait, usually around 24 hours.
And there's actually really interesting new research that's coming out about icing in general, and that ice may not be like the greatest thing for injury and inflammation anyway.
Don't tell the orthopedic surgeons that.
Yeah.
Their answer for any of their problems after surgery is just ice it, you know?
Yeah. So it really, there's, like Dr. Martin said, there's not a lot to do in recovery. You just kind of take it easy. This is another great before and after picture.
We're showing up before and after. You can follow us on Instagram at Jason Martin MD on Instagram or Facebook.
This picture's on our Instagram
And
page.
if you look at our wall, you can see it. And this is a really good. And I like this. I like this picture probably more. That it has nothing to do with what we did. It's the fact that between the before and after, the guy started working out, lost weight, went on anti-estrogen medications, and he got totally jacked up. Mm-hmm. And I was like so impressed when he came in because all of a sudden his shoulders are more broad, and he's like, okay, you're being kind of weird, Dr. Martin. I'm like, God, you look great.
It was a pretty shocking transformation. And this was a good example of a patient who we did the gynecomastia surgery on. He came back because he had a reoccurrence.
Yeah, and then he had to go to a super specialist, and they put him on, I think it was tamoxifen or one of those anti-estrogen drugs.
Yeah. But he actually came in, like we scheduled him for a revision, meaning we were going to do a little more liposuction. But when he came in, it was like, no, like you need to go.
Like you could feel the breast bud there.
Yeah, like
and
it was quick.
Yeah.
I mean, it was like within 6 months. Like something else is at play here. So please go see an endocrinologist or a hormone specialist before we do this, and let's just make sure.
Yeah, he saw an endocrinologist.
So when he came back, I mean, we did end up doing a small revision because he had regrown some breast tissue. So this was after his second procedure with us, just in full disclosure.
Yeah, but I actually probably should have said that. I said internist, hormone doctor, but really an endocrinologist is the person who's going to deal with this mostly. But the problem with endocrinologists, it takes like 5 years to get into one.
It does. They're hard to get into, and it's hard to find a really good one.
I mean, can we just train some more endocrinologists? I mean, there's like 3 in each state. And like, how do you have a residency program? Like, I don't even understand. Like, I think it's artificially suppressed.
But it's because the endocrine system is...
Well, I mean, why don't you just train more endocrinologists?
Yeah, I don't know. I think maybe people don't want to like get into that train. Whereas to me, I'm like, I find it fascinating.
It's cool. I mean, I would do that.
So cool. Yeah.
I like surgery better. But.
Yeah. But this patient truly had an amazing transformation. I mean, it was so cool. Yeah. So pre and post-op considerations, we kind of talk about this with all of our procedures. We talked a lot about what makes a good candidate. One of the main things to consider post-operatively is just that you will be wearing a compression garment for the first 4 weeks. Now, again, most of our patients prior to this surgery are probably wearing compression shirts anyway and or loose-fitting clothing, but we do want you to have some compression on that area for the first month following surgery. We also don't want you doing any direct chest work for the first 4 weeks. You can get back to some easy workouts at 2 weeks, but nothing for those first 2 weeks except walking, and that's really because we don't want you to develop post-operative swelling or bleeding, and getting your heart rate way up can do that. So just taking it easy. Other than that, there's really not a lot of restrictions. Most people could be back to work probably the next day if someone's doing something that's not physically active. Most of the time we schedule these procedures on a Thursday or Friday, and people
we're
are back
even
to work
taking
on Monday.
into account that men are sissies compared
That's what
to women.
I was trying not to say that.
And
but
I'm a man.
Yeah. But it's, you're achy and sore, but it's in an area that's pretty easy to tolerate achy and soreness.
Like the core really hurts, but like the chest, you can get around it. I mean, you just do alligator arms, basically keep your elbows at your side, and you don't really activate the pectoralis major muscle, the chest muscle that much, so it's not that bad.
A little sore when you sleep, it's going to be a little achy. You might have a little bit of bruising. You'll definitely have some swelling, might have some bruising. A couple weeks later, you're pretty much back to all your normal activities, and in a month out, you're usually released for all activity.
Right.
You might have a couple of sutures. We try to close all of these internally just because those heal the best. Dr. Martin is pretty much like the magician at closing things completely suturelessly from the outside.
Can we have an episode on me being a magician?
Oh my gosh, there'd be so much. Oh, yes, we should. I could collect stuff and be like, this was a time when Dr. Martin was like, did something really awesome.
Yeah.
There could
the
be
best
so
is
many.
When you have really short sutures and you don't think I can do it.
See, I was going to bring that up. Like when I give you like an inch and you're like, oh, I got this.
I got this.
Yeah. Mm-hmm.
Everyone's like, they're so enthralled right now with our conversation.
Right. See, and my favorite though is when it's so short that you like actually pull the needle off after you throw it, and then you like somehow magically tie it with like a needle driver and a pickup.
Magic.
It's magic. So yeah.
I don't really know where that gets me in life, but it makes me good at surgery. So
it's impressive.
Gynecomastia 2.0.
Yeah.
So, I mean, there's so many things that are changing, and we're going to have to reboot some of these topics and bring them back, and we'll denote it with the 2.0 moniker.
Or 3 or 4.0. But we also would love questions. So people, if you have specific questions about any of these procedures, we have answered questions from listeners before, and we actually really love doing that because while we think we cover most of it, I don't know what your specific questions are about gynecomastia.
But every single one of those, they always bring up a good point.
Yep, they do. That's what I mean. Like, so
Which makes you wonder if there's like a lot of people listening, and we have a pretty big audience now, and they're like, oh, they didn't talk about this or that. Just write in.
Yeah.
We'll talk about it. It's not a problem. We'll take care of it.
That's right. We'll take care of your questions. So again, if you would like to see the videos and slides that accompanied this podcast, you can find those on YouTube at Jason Martin MD, and also on Instagram at Beauty and the Surgeon Podcast, and at Jason Martin MD on Instagram as well.
You can go on our website too, because we're going to have a page dedicated, or we do have a page dedicated to gynecomastia. We're redoing our website this month, and it's going to be released at the end of the month. So if you go on when this episode is released, it may be under construction. Bear with us.
If it's after, it's old news.
Yeah, bear with us. After that, it never was under construction. It was always the way you found it. And yeah, I think me personally, this is the one of the few surgeries. I mean, all surgeries I love to do, but this really invigorates me because I feel like we're helping a subset of the population that many times didn't know they could be helped.
Yeah,
and it makes you really feel good. So, plus, guys, men in general, I'm paraphrasing here, summarizing, have a tendency not to be totally connected with their emotions and self-perception. A lot of times they keep things deep down inside, as we know, tends to fall into that, into those types of people, which are men. And so this problem can be fixed in less than 2 hours, and it could transform their life. And I don't want to overstate that transformation, but it really is. You see that in the people that come in. They feel it's like a weight's been lifted off their shoulder or their chest, and they look different. Mm-hmm. So if you struggle from gynecomastia or male breast, seek help. And there are tons of people out there, board certified plastic surgeons, physicians. If you
definitely go to a board certified plastic surgeon.
Exactly. If you can get into an endocrinologist, good luck. But seek help, because there really is answers, and we mean that, and that's why we wanted to do this topic again. So that's all I got, Amy. That was my soapbox speech.
I like it. It was a good soapbox. So please be sure to leave us a comment if you have a comment or a question. We love those, and rate us and review us. Share us with your friends. We really appreciate all of you for listening. And until next time.
Until next time.